No. Okay. Now I'm going to introduce Petar Janevski. He's going to give us a lecture with the topic Lightning Strike Twice, managing recurrent thrombotic complications in a single aneurysm.
Thank you for the invitation, Dr. Janevski. Good evening, everyone. This is actually a case that I already presented in Bulgaria at last year's MENC meeting in Plovdiv. So it's a case of a ruptured aneurysm that took 2 sessions to treat. And during both sessions, we had 2 thromboembolic separate events. I have nothing to disclose. The story started when this 52 years old female had a ruptured parophthalmic ICA aneurysm. And we decided to coil the aneurysm. Of course, no antiplatelet therapy was given because it's a ruptured case, only IV heparin during the procedure. In this case, we opted for non-occlusive remodeling net assisted coiling. And for our weapon of choice, we chose the cascade device. I don't know if anyone knows the cascade device. It's basically an older version of Comaneci, but it's the mesh is much denser, and that's why it's more thrombogenic, but we didn't know that at that time. This is the procedure itself. As you can see, one microcatheter is in the MCA for the deployment of the cascade device, and the other microcatheter is in the aneurysm. So we started our coiling procedure. We unsheathed the cascade device. We did the scaffolding for the coils. We continued with the procedure, and after 6 or 7 coils, it took like 10 minutes maybe, we were afraid that we would have some thromboembolic complications because the patient was not on double antiplatelet, it was ruptured aneurysm and everything. And of course, our worst fears came to life. As you can see, we see the filling defect of the M2 of the MCA. So at this point, we stopped our coiling procedure. And we wanted to, first, we thought about stent retriever, but we were afraid to pass through the coil mass. So we decided to go with our rescue strategy with tirofiban. We gave intra-arterial bolus of tirofiban, then in the next 12 hours, intravenous tirofiban. And the lady was discharged after 2 weeks without any neurological deficit. As you can see, this is the control CT before discharge. She's some small cortical infarction. And I don't know how it is in Bulgaria and in Bosnia and Serbia, for example, but in Macedonia, patients, when they come out of the hospital, they say, we're cured. They don't come back at their scheduled appointments. So this was the case for this lady, and she came back after 1 year with a CT done in another hospital, on which CT I saw that the aneurysm is, of course, recanalized because it was not coiled in the first session. So we did a DSA. This is the 3D run of the recanalized aneurysm. As you can see, there's outflow stenosis. Our strategy here was to put flow diverter, of course, and we scheduled the lady for 2 weeks after this initial DSA. As you can see, the stenosis is at the level of the dural ring, but we were expecting some troubles here, and we were prepared with balloons and everything. So we gave the patient double antiplatelet therapy 7 days prior to the intervention, and did the clopidogrel resistant test. This is the first run. The deployment of the stent was FredX. Deployment of the stent was uneventful, but as you can see, as we predicted, it didn't open at the level of the stenosis. As I said, we had our bailout strategy planned. Well, our balloons were right next to us. So this is the run after the deployment of the flow diverter. And we thought maybe we got lucky, we don't have to post-dilate. And per our protocol, we waited for 10 minutes. to do another run. And of course, this happens. If this didn't happen, I wouldn't be here. I mean, it's a complication that we expected, but we hoped that our neuromax had fallen down into the external carotid artery. So we went down to check, but unfortunately the neuromax had fallen down a little bit, but it's still in the ICA. And we knew that the flow diverter was occluded. But I don't know if you noticed, the patient is awake. We do these procedures usually in conscious sedation. And we knew we had time. We didn't do a cross-flow check before that, but we knew we had time because of this. So our rescue strategy, again, tirofiban intraarterial bolus and then infusion, along with aspiration thrombectomy in this case. So we used the Sophia 5 that we had for the procedure. We aspirated till the end of the stenosis because, as you can see, the Sophia 5 could not pass the stenosis. So we tried first with a scepter balloon, but it burst. So we took a semi-compliant neurospeed balloon and did the PTA at this level. As you can see, even the coil mass is moving after the dilatation. And this is the control run. The flow diverter was recanalized, but there was still some thrombus on the wall of the flow diverter, but we left the tirofiban to do its job. We scheduled the lady for regular checkups, and we did a 1-year follow-up. This time the lady showed up on time. As you can see, the FredX is fully expanded, and we did the DSA. As you can see, really nice remodeling of not just the aneurysm neck, but the whole stenotic segment of the aneurysm. This is the end run. So in conclusion, thromboembolic complications can happen during of course, the ruptured cases, especially if you use the bare metal devices, and they can happen even in scheduled elective cases. Thank you.
Thank you. Petar, any questions or comments?
Thanks for sharing. I just should maybe comment that the cascade is the second generation, coming later the Comaneci. We were involved in the first in human, and we were happier that it's more braided, because with the Comaneci we experienced one or twice entangling with the coils.
Of course, I know. Yeah.
So we decided we will never see with the cascade, but of course we see a lot of such things. So I started, we have to do the first 10 cases. Just to know, maybe unintentionally, I didn't completely retract the cascade. So it goes a little bit left of the first. The first handle was sliding, the second was like ticking.
Ticking, yeah.
So I don't know which one you are using.
The ticking one.
So the kicking one, we left one of it like open, so halfly retreat to be out, and like 2 or 3 times of 10 cases, we observe this thrombus inside like the device. But you halfly open it, remove it, and you can observe it in it. So for Comaneci, I have cases, both Comanecis of basilar tip, left for 25 minutes with no thromboembolic complications because maybe of the less density of the device. With the cascade, like 5-7 minutes, you can observe thromboembolic.
I've experienced thromboembolic complications also with Comaneci, but I learned my lesson. I don't use them in ruptured cases. So
I use them only in ruptured cases. I don't use in the elective case because I prefer to put a permanent stent. I'm not afraid of using double antiplate.
Of course.
If it's elective and there is a like slight chance, say 10% of recanalization, I prefer to go for a permanent stent. Yeah. But in rupture case, sometimes it's a bigger one. I don't want to deflate the balloon every 2-3 minutes.
And how
I
much
go for the Comaneci.
heparin do you give?
5,000.
Only 5,000.
Like maybe I was lucky. So Comaneci is 25 minutes with no complication. So it depends of the time for sure.
Any more questions?
Okay.
Thank you.
Thank you.
Now I would like to introduce next speaker, Mihail Klanev. Will give us a lecture about the ghost pseudoaneurysm, a clinical nightmare.
So, hello again. For those of you who are not here, my name is Dr. Mihail Klanev. I'm from Department of Neurosurgery from University Hospital St. George in Plovdiv. I want to present a case that involves different specialties from our hospital and also from St. Ivan Wilski in Sofia. So this is a 70-year-old male patient who was diagnosed with choroidoma. Pardon me for the mistake here, in 2014. These are his initial MRI scans. You can observe the tumor formation on the base of the cranium, here, and you can observe also the positioning and the involvement of the internal carotid artery on the right side. So I have to mention that this patient was a patient of our director of our hospital. He's ENT surgeon. So at that time, he still has good connection with the colleagues in Germany, and he sent the patient for tumor resection in Germany, actually. So the patient received 2 operations and also proton beam therapy in Germany. So after a long time period with no symptoms, he arrived in October 2025 with symptoms of epistaxis on the right side, and CT scan, CT angio, MRI was performed. Here you can observe the CT angio, and the colleagues wrote that there is chance of pseudoaneurysm there. So one of the colleagues from ENT called me and said, Michael, look, you should do a DSA. And of course we did. These are the AP and lateral projection on the right side. And here I'm not able to see anything. So we called back and said, look, there is nothing to see here. We presented the sphenopalatine artery on the right side. Maybe the bleeding is from there. They were satisfied with the result, so they went on Saturday for attempt to coagulate the artery. But when they removed the packing from the nose, massive bleeding started. So they called us and said, look, there is something. It's not only this. Our director called one of the neurosurgeons in St. Ivan Wilski, who is dedicated in transnasal resection of tumors, and sent the patient in St. Ivan Wilski. Here, Professor Sivakov discussed with the colleague from neurosurgery, and they decided to try to embolize, and they embolized the both sphenopalatine arteries on the left and the right side. You must believe me, I don't have their DSA, but there was no pseudoaneurysm there, so everything was clear, and they decided, as we told, that the bleeding is from the external carotid artery. Unfortunately, a week later, during one of my spine surgeries, I have been called from the colleagues from invasive cardiology, and they told me, Dr. Klanev, you should come here. So immediately I went in the angio suite of the invasive cardiology, and here we can see this pseudoaneurysm. Dr. Klanev was trying to put carotid stent there, and he asked me, what do you think? Can we manage this? So I called Professor Sivakov, and the opinion was to try to implant the carrot stent and see what's going on. So I don't have experience with carrot stent, but it was not possible to put the carrot stent that high, so it was quite rigid. And during the procedure, the patient have shown signs for hemorrhagic shock. So the colleagues immediately put another tamponade, so another nasal packing, and Professor Sivakov immediately came from Sofia because we didn't have in our angio suite flow diverter. With the flow diverter, because the idea was to, of course, put a flow diverter and try to embolize this aneurysm with flow diverter. These are the images from our angio suite. You can observe the pseudoaneurysm, but of course, we tried to put a flow diverter, but unfortunately, so the flow diverter was P64 and the microcatheter was Phenom 27. Without we cannot say why, but there was trouble putting the flow diverter. So, we don't know if it was the catheter or the stent, but it was not possible to load the flow diverter into the stent. I have never seen such thing before. But unfortunately, this was the situation, so we decided to code the aneurysm. But when we did the 3D angio, we saw that there is a stroke. So now there is a stroke in the M2 segment of the middle cerebral artery on the right side, and we have to do thrombectomy. Of course, we did the thrombectomy. Here you can observe the stent. Here you can observe the microcatheter. This is the injection from the microcatheter and the stent. So we did thrombectomy with stent retriever and aspiration catheter. And we managed to recognize the artery. So there were some distal clots, but of course we decided not to push any further and give tirofiban. And we proceed with clearing of the pseudoaneurysm. These are the CT scans after the procedure. You can observe that there is no intracranial bleeding, but unfortunately you can also see the bleeding inside the nasal cavity. This patient was never extubated again, and unfortunately 10 days later he passed away. So it's really interesting case for us because this pseudoaneurysm was not seen in two different departments, on the angio, MRI scan, and 2 DSAs. And unfortunately, we have no explanation why it was not visible. And after that, during the procedure, we have no explanation why there was malfunction of the catheter and the stent, but it is what it is. Thank you for your attention.
Did you mention it has radiotherapy for the?
Yeah, proton beam therapy, but it was back in 2014.
In my mind, it's happening.
Yeah.
Thank you for showing that. I think I would do certainly different things, in different steps. Let me start with from the operation. And CT clearly show you that in the medial wall of the internal carotid artery has no ball.
Would you put slides, please?
No osseous structure. And then that means the artery itself is touching the air. And that the clinical
findings is the bleeding,
Correct.
and not the small bleeding, is the massive bleeding.
Yeah.
And again, the axial CT also clearly showing you something there in the internal carotid artery, over there. See?
Yeah.
That's enough.
That's our thinking for the region of the carotid.
That is enough. You know, there's a bleeding, and here, and this is a big suspicion that there is a dissection over there, or kind of a radiotherapy-induced pseudoaneurysm, or in together. And then you did the angiography. Show it to me, please.
Yes.
Yes. That is it?
Yes.
Wrong. Sorry. Now we are talking. Now we
Yeah.
that is we are exchanging the knowledge. This is not enough. This is conventional AP lateral. You need to do 3D. You need to do intra-arterial flat panel detector CT angiography if you have an ability in the angio. Do you have?
Yeah.
But you didn't.
No, we did AP lateral and
Oblique.
45. Oblique, yeah, correct.
Not enough. These are not enough for blister aneurysm, ghost pseudoaneurysm, or intra-arterial dissection. Vaso-CT or Dyna-CT intra-arterial injection can show the dissecting part. And also, did you do a compression test?
No.
That is also another thing. You need to do it in those situations, because if I had an bare internal carotid artery touching the air and have a massive hemorrhage, if I have a anterior communicating artery and posterior communicating artery, if I come to your center, please occlude my internal carotid artery. Please.
Okay.
Okay? Don't deal with that, the flow diverter and other things. Maybe the cover stent is okay. We did a lot. A traumatic internal carotid artery treated with the cover stent in that segment is okay. But if you don't, please do the parent arterial occlusion, because you didn't check the ACOM and PCOM position. This type of things led you move forwards for different technique. And eventually what happened, the thrombectomy and then the coiling, and it is something else.
Can I just ask if in this case, that imaging, you have a good collaterals, are you going to sacrifice the vessel?
Yes.
Here, with this
If I have the massive hemorrhage, I will not occlude the sphenopalatine arteries.
so that's one
Because,
I told him I don't believe this is dissection.
no, we're discussing now.
Yeah.
That,
But at that level, I didn't think for a sacrificing vessel. I
uh,
was here concerned about the city. I think on the city I told you we have
Yeah.
occlusion here, for sure.
Yeah.
Same thing for angio.
maybe,
Angio, I wasn't sure there's something wrong.
May I ask
It's
something?
also my mistake here. He consulted with me, and I told him, okay, let's wait.
we are not talking about mistake. We are talking about
Retrospectively, this is a mistake, so we can learn from this.
I may explain our approach in any kind of traumatic the parent artery lesions. First thing first, if we have a massive hemorrhage in the nasal area, we are alarming. Even we didn't see the pseudoaneurysm. We are alarming. You may not see the aneurysm itself. Especially without doing the vaso-CT, you may not see the lesion. But if you look at that is in the sinus. It's sinus, and there is a lesion there already ruptured here, huh?
Yeah.
Yeah, it was already ruptured.
Yeah, but
here.
without packing. I want to show it. So there is no packing in the nose right now.
Doesn't matter. That doesn't matter. I mean, the first thing first, you need to check the collaterals, you need to do the optimum imaging, and then decide afterwards. At least I would do a cover stent here. Do you have a cover stent in Bulgaria?
We have it. I don't have experience with putting above the
Balloon mounted cover stent.
Yes, above C1 segment above the curve I have.
So the colleagues from invasive cardiology tried to do this, but there was massive tension, and every time the stent was going up, it's actually the stent by itself
But
was
it's
protruding.
self-expandable Boston Scientific stent, I believe.
Pardon me?
That is self-expandable Boston Scientific stent. It's a carotid cover.
It's covered stent. I don't know what kind of covered stent were there.
That is rigid. That one is rigid. I
That-
believe
it
that
was
one.
quite rigid, and
Yeah, yeah.
every time was protruding inside a pseudoaneurysm.
I
So
see,
it was
yeah.
quite dangerous to
Yeah, yeah.
push it.
Okay, now see the lesion correctly. I'll go with coils and blower, and I just took one for the doctor to blow, and we have problem introducing it.
Yeah, yeah, yeah.
So we left with in hemorrhagic shock. We saw the histotrombone. Okay, let's do histotrombone. We can do it very gently, go very nicely.
Yeah.
in the proximal part of the aneurysm. Again, at that level was not thinking of sacrificing the heart. Even didn't propose you a program.
No.
This is the approach, I believe. You know that
If it's missing,
the next year, if you invite me, please give me a lecture about the non-visible arterial lesion, which is visible for intra-arterial vaso-CT or dyna-CT angiography. And I will give you some examples about dissection and the bilisteral aneurysm, and then we may discuss about this. Do we have an optimum imaging or not? This case is, yeah, unfortunately, yeah, it's a complication case. But look at these images. I may show you many cases like that.
Okay. I appreciate it. Thank you very much.
No problem. Don't misunderstood me. Thank you
No,
for showing. Thank
this
you for
why we're
showing
showing
and
this.
discussing with that.
Thank you. Thank you, Mr. Thank you. So the last speaker, Mihail Petrov, M1 occlusion, a simple 30-minute case or a possible disaster. Welcome.
For staying for the last lecture. Okay, so I'll show you some of our most interesting cases, and we'll focus about M1 occlusions. I don't know how many of you are doing stroke, but maybe this will be your first stroke cases, as they are most common, and most of the people think that they're easy cases. So we made some retrospective review of all our patients for the last 3 years. There were around 175 patients endovascularly treated with large vessel occlusions. From these patients, the stroke was in the anterior circulation in 93% of the cases, and the occlusion was in the MCA in 72% of the cases. When we retrospectively looked in all of those cases, we found around 35% of the cases that we thought from the initial imaging that it would be a simple M1 occlusion, and it turned out to be something completely different. You can see the results so far in our university hospital. We have in the graphics are all about MCA occlusions. So we have around 90% TK2B recanalization. Most of the time we try to start with just aspiration in order to be as fast as possible. It's not always possible to try first aspiration from anatomical reasons, so on. You'll see in the few cases that we have shown. And this is the MRS that we have reached, 54% discharged below MRS2. So looking back at all of the cases, we pointed out several problems that might occur during M1 thrombectomy or M2 thrombectomy. Some of the cases turn out to be tandem occlusions that weren't pointed out by the radiologists that conducted the CTA. Some of the cases it was kind of difficult to find the thrombus. Some of the occlusions turn out to be dissections, and a few of the cases, less than 5%, turn out to be an ICAT. So we'll gradually talk through fast through the cases. We won't talk about the symptomatology, just focus on the imaging. This was a case that was referred to us with an M1 occlusion. That's when carefully looking at the images, there are a few points that should be taken into account. Always look at the CTA, follow the ICA, even in the Petrov segment, because when we looked carefully in the Petrov segment, we saw that there was no filling. So we already knew that it wouldn't be a simple MCA occlusion, and we are talking about a tandem lesion. So when we started the case, we saw this stagnating contrast in the left ICA. We did a couple of fast aspiration with an intermediate catheter. I think it was a Sophia 6 French. That led to recanalization of the ICA. Then there was still a thrombus in the MCA, a quite long thrombus. We did a pinching technique, a combined one with the aspiration catheter and a stent retriever. Still there was a thrombus, and did one last aggressive aspiration with an aspiration catheter that led to the TK3 recanalization that you can see here. In the other case, it was much more interesting than the first one. On the initial plain CT, you can see a thrombus starting from the left M1 going to the M2. You can actually, on the CTA, when you have good collaterals, you can follow the thrombus and know how long the thrombus is in order to appreciate what kind of stent retriever to use. When we always look below the skull base in order to see the Petrov segment, you can appreciate on this picture that there is slightly less contrast in the Petrov segment. This led us to look even below, and we saw this stenosis in the ICA, in the bifurcation. So it was kind of a battle in our hospital to always perform CT angio from the aortic arch. It's very important in order to plan your thrombectomies, in order not to miss and not to be surprised from tandem lesions. So what we found during the angio, this was a complete occlusion of the ICA at the bifurcation. We did angioplasty in order to pass with the aspiration catheter and the stent retriever. We did a combined technique again with the stent retriever and aspiration catheter. And this was our final run, complete recanalization of the MCA. And this was the end angio of our ICA. I'm not sure how many people from the audience are doing carotid stenting, but if you want, you can share how many of you are going to stent this directly, because there was different opinions in our angio suite what to do with this ICA stenosis. If you want, you can share if someone's going to stent this directly, because we weren't sure at that time. So when we have some different opinions, and at the end of every thrombectomy, we do an expert CT. So this is our final expert CT. We can see some contrast in the basal ganglia. So because there was no stagnating at the bifurcation of the ICA, we postponed the stenting. You can see actually that this was the right decision, because this is a CT after 24 hours after thrombectomy. There is always a little bit of hemorrhage, but this point over here, this is actually an acute bleeding that when putting a patient on a double antiplatelet therapy, it would have turned in a massive intracerebral hemorrhage. Actually, this patient 2 weeks later was stented, and now his MR is 0. Another case that was kind of difficult to find the thrombus, because on a plain CT and a CTA, you can always appreciate where is the thrombus, but during an angio, sometimes it's not so easy. Of course, these cases usually come in the middle of the night. So when you do an AP, you might at first become a little bit confused. And actually, this is not the MCA. So this is fetal type ICA. So this large vessel here, this is actually the posterior communicating artery, which actually leads us that this is not an MCA occlusion. This is a carotid T occlusion, which is another kind of case, quite difficult, because sometimes it's very difficult to find where starts the MCA. So after 3 or 4 attempts, we managed to do it. Here is the stent retriever with the aspiration catheter. And this is the complete recanalization of the patient. The next case, we knew from the initial CT scan that we are dealing with a hard clot. You can actually see that it has almost a density of the bone of the patient. With some other reconstruction, you can actually appreciate that maybe this is a trifurcation of the MCA, and we knew that there would be some problems with retrieving the clot and getting there. So what we did the angio, and at first we were actually a little bit confused because the first angio showed a very good MCA. But still there was something bothering us, the severe symptomatology of the patient, and always we look for the late stages of the angio, and what we saw, it was this one here. This one here is a stagnating of a contrast inside the MCA, and we couldn't appreciate from these projections where the clot actually was. So what we did when we have such difficult cases, we always do a 3D angiography. We did it, and actually this is what we saw. We saw a not complete occlusion of the dominant M2. We did the same projection from the 3D with with a slightly angled view of the angiographer, and this is what we saw. This is actually the thrombus. When we know where to go, it was quite easy. It was a single pass thrombectomy with an aspiration catheter. So you can actually see this is the imaging after the thrombectomy. There is considerable difference with preoperatively. So when we are not sure, we always do a 3D. This is a quite difficult case. Unfortunately, it came quite early in our endovascular career, let's say it like that. It was a patient that was referred after ski trauma. He came with slight hemiparesis. What we actually show from the hospital that referred it, it's a dense MCA sign. When we took the patient to the angio suite, we actually saw this, let's say, occlusion. We thought that it might be a dissection of the MCA. We tried several times to pass through the dissection. We actually did it. We tried a thrombectomy with a stent retriever. Even the wire you can see here occluded the MCA. After one of the passes, we actually did a little bit another problem, an ACA occlusion. So we had to deal with that also. You can see how very small aspiration catheter, I think this is a 4 max, how it takes the curves and goes to the A3 segment in order to complete the thromboaspiration. This is the result. We didn't want, because this was a polytrauma patient, we didn't have at that time special intracranial stents, so we tried just to at least perform some kind of treatment for the dissection. We left stent retriever for 15-20 minutes. We put the patient on antiplatelets. When we saw this result, we thought that it will be better than rupture the vessel with a stent that's not supposed to be there, like a coronary stent and so on. But maybe looking back at this case, we would have stented this patient if it comes tomorrow. Another case, it was a very interesting patient because it was referred from another hospital because the patient had simultaneous myocardial infarction and a stroke. They didn't know how to cope with such a patient in the other hospital, so they sent it to us. We did it simultaneously with the invasive cardiologist. We started with the brain. You can see there is already some ischemic damage in the right hemisphere. But it was a 45-year-old patient, so we just went for, in order to save his life. After maybe 3 or 4 passes, two thromboaspirations, after that, 2 passes with the stent retriever. This was actually the best result that we could achieve. And at that point, we found that we are not dealing with a simple MCA occlusion. This is probably an ICAT. So what we did, we actually tried a new device on our shelf. I don't think it's still in Europe. Its name is Odyssey. It's supposed to treat ICAT. Unfortunately, this device was a little bit longer for this segment, but we didn't have another size. So we tried with the Odyssey. Unfortunately, it didn't help. So we went for emergent stenting. We put a Pegasus stent. After that, the invasive cardiologist did the coronary intervention. And when we came back, unfortunately, the stent got occluded despite the thyrofaban. So we went for angioplasty of the stent. And actually, this is the final result, complete recanalization of the vessel. Unfortunately, this is the expert CT. Very massive hemorrhagic transformation. This is the contrast. This is 24 hours later. Fortunately, the patient didn't develop very huge edema, so we didn't have to do decompressive craniectomy. Now the patient is MRS1, maybe 1 year after the intervention. This is our last case. This is a patient that had his stroke, I think, in the Czech Republic while he was driving back from France. They did need a plain CT, they didn't find anything, and he actually was able to drive back from Czech Republic to Bulgaria. When he came to our hospital, it was around 30 hours after the symptom onset. This was his initial imaging. So we saw this small ischemic area, but very small one. We saw this occlusion of the M1, M2 transition. Despite the long hours after the symptom onset, we talked with the relatives and thought that this was the only chance. At this point, the patient was hemiparetic, so we went in the angio. We saw this M1 occlusion. We did a few passes with Sophia 6 French. You can actually see even parts of the thrombus going through the sphere. This was the result after the thromboaspiration. We saw that it wouldn't be the only technique that we'll try. You can actually see this dipping MCA. It was discussed before that. Dipping MCA with just a stent retriever is a bit dangerous because the lenticular arteries are coming from this segment. So every tension should be tried to be overcome with an aspiration catheter. So if it's possible, the aspiration catheter should be as close as possible to the stent retriever in order to at least try to change the arrow of the force that you are applying, because otherwise you might get torn lenticular arteries and have a major ICH. So we tried a few times with a stent retriever in place. This was the best result that we achieved. We saw that there is stagnation in the dominant branch of the MCA. We waited for 15 minutes. We started thyrofaban, but even though we waited enough, there was occlusion, so we put a Pegasus stent. There was slight stagnation here in the other two branches of the trifurcation, but everything turned out fine. This is an angio 3 months later with a very good result. The patient is completely asymptomatic and back to work. So the take-home messages from our small cohort of around 90 patients: do your imaging from the aortic arch in order to get prepared and not to miss the tandem occlusions. Observe carefully the preoperative imaging, the plain CT, the CTA, even the carotid arteries in the neck and in the Petrov segment. Be prepared for problems, try different techniques, and be ready to always execute Plan B.
Thank you, Mihail. Some questions? So we can close the session. Thank you to all the participants, all the faculty members that shared your experience. Probably we will go home like better doctors to treat better our patient. Thank you. Thank you.